my voice is audible?
Yes. Sir, can you please put your monitor screen little bit down?
क्या
आपका जो फेस है ऊपर से थोड़ा कट हो रहा है सर. Okay, that's fine. Now it's fine, sir.
Yeah.
Okay, so on a 3, 2, 1. So we are live now. You can start the talk. Over to you.
Yeah. Welcome everybody. My name is Dr. Sanish Shringarpure, and I am a urologist and consulting andrologist. I have got my clinic in Kharghar, Navi Mumbai, and I'm attached to Apollo Hospital in Navi Mumbai. And also I'm the andrologist at Apollo Fertility in Navi Mumbai, Thane, Borivali. So I have written 2 books. So that is, first is Let's Talk About Sex. So that is a complete answer to misconceptions in parents, adolescents, unmarried and married adults about sexual issues. And second is Let's Talk About Kidney Failure. So these both books, they are available on Amazon as an ebook as well as an paper book. So you can go through that. So without wasting any further time, I'll start with the main topic. So today's topic is management of erectile dysfunction. As you know that erectile dysfunction is such a problem which not only affects the elderly, but nowadays with the increasing stress and strain of the world, with the hectic lifestyle and ever-changing demands of the today's fast-moving lifestyle, this erectile dysfunction problem is affecting even the younger population. And in that, I come across not only married, but even the unmarried young adults. They come with a lot of sexual issues. So erectile dysfunction is such a problem which not only comes to urologists, it comes to gynecologists. These patients are seen by physicians, common general practitioners, surgeons, all specialties. And it is a such topic that everybody should be aware of. And it's a very common problem which is affecting with today's lifestyles. So following presentation, this is like a statutory warning. The following presentation may contain some mature themes and minor graphic events which are not intended for the younger audiences, and viewers' discretion is advised. So this is like a statutory warning. So now I am going to give you a live breaking news. So ED seizes assets linked to Sanjay Raut. ED officers seize the assets linked to Rahul Gandhi. Now here ED does not mean erectile dysfunction. Here ED is the different ED. It means the Enforcement Directorate. But this is the ED which is quite sufficient to give ED to the politicians. So our main topic here is erectile dysfunction. So let me give you the breaking news about the erectile dysfunction. Now, erectile dysfunction, according to the WHO, that is the World Health Organization, has defined WHO as consistent or recurrent inability of a man to attain or maintain penile erection that is sufficient for sexual performance. This has been defined by WHO in the first consultation on erectile dysfunction 1999. In that, the National Institute of Health Consensus Development Panel, they further specified that the recurrent inability should be more than 3 months. So this inability should be recurrent and it should be more than 3 months of a man to attain or maintain sexual erection which is sufficient for sexual performance. So these 2 criteria should be met, only then you can say that it is erectile dysfunction. So erectile dysfunction has been quite glorified in our Hindi Bollywood cinema thanks to Ayushmann Khurrana. Now Ayushmann Khurrana, he has played the role of a sperm donor in Vicky Donor. Ayushmann Khurrana has played the role of a gay person in Shubhamangal Saudhan. So our medical fraternity is quite thankful to Ayushmann Khurrana. Now let me give you the significance of this problem. Now ED is a common health problem which affects men between age of 40 to 70 years. So a recent survey was carried out between the age of 40 to 70 years, and 48% did not have erectile dysfunction. So 52% race had a problem of erectile dysfunction, out of which 10% had complete erectile dysfunction, 25% had moderate level, and 17% had minimal erectile dysfunction. Now, a study of sexuality and health was carried among the older adults in the United States, and a questionnaire survey was given, and 3/4 of the population who attended the survey were between the age 57 to 64. Half were between the age 65 to 74, and 1/4 of them were between the age 75 to 85. And women were always more than men in all the ages who attended the survey. So among the respondents who were sexually active, both half of the men and women, they reported at least there was one bothersome sexual problem. Erectile difficulties, that is, were present in 37%, and out of that, 14% of the men reported use of some medication or supplements to improve the sexual function. ED affects as many as 50% of the men over the age of 40. Now, a recent survey was carried out in India of the erectile dysfunction by a pharmaceutical company. 20% of men across all the age groups and 30% of men younger than age of 40, they battle ED. So this is quite a significant figure. Then a study was carried out among the various metropolitan cities, and in that 75% of the men and 66% of the women think that erectile dysfunction is not an old age problem. And in that, the highest population is in Mumbai. In that, percentage of men who believed that old age is the reason of erectile dysfunction is highest in Mumbai, 30%, followed by Delhi, then Bangalore, and then Calcutta. 28% of women might consider separation if the partner does not take corrective treatment for erectile dysfunction. 42% substituted the medicines prescribed by the doctors with the cheaper options and opt for pharmacist suggestion. 96% of the doctors agreed that the partners played a significant role in the success or failure in the treatment of erectile dysfunction of a man and may influence decision regarding the treatment or even its continuation. So in the recent COVID outbreak, there have been increase in the number of cases of erectile dysfunction. So this was a paper which was published in the Journal of Endocrine Investigation about COVID and erectile dysfunction. And they have found out the reason that the SARS-CoV-19 virus, it causes psychological stress, decreased sleep quality, and also reduces the sexual hormone production, causing erectile dysfunction, decreasing the sleep quality. So there was an increase in number of cases of erectile dysfunction despite the lockdown, despite the husband and wife being in the same room, in the same house. There was an increase in the cases of erectile dysfunction. Now, before going into erectile dysfunction, I want you to understand how does a normal erection take place. So a normal erection, it relies on combination of psychogenic, hormonal, neurological, and vascular factors. And there are three types of erections. One is psychological, reflexogenic, and nocturnal. So a normal penile erection, it requires neural transmission of proerectile impulses. It requires an intact arterial blood supply and requires functional erectile tissues in the corpus cavernous. So an erection, it starts in the brain. So there is sensory or mental stimulation is followed by a burst of chemical called nitric oxide, which functions as a neurotransmitter. The nitric oxide causes smooth muscle enzyme called guanylate cyclase to produce enzyme called cyclic GMP, which increases the size of the blood vessels carrying the blood to the penis, decreases the size of the blood vessel carrying the blood out of the penis. When the smooth muscles are relaxed, blood flows into the arteries, fills the spaces. This creates pressure in the corpus cavernosa, make the penis expand. So I'll show you a figure. This is the cellular mechanism of erectile dysfunction. So this is for the medical professionals. So when the endothelial cells are reacted by this nitrogenic nerve because of sexual stimulation, nitric oxide is secreted. This causes release of guanylate cyclase, which convert GTP into cyclic GMP, which acts on cyclic GMP specific protein kinase, which decreases the intracellular calcium and causes smooth muscle relaxation. So here is the site where the PDE5 inhibitors act, and they decrease the concentration of this, decrease the conversion of this cyclic GMP into 5-GMP, causing increase in the intracellular calcium, causing smooth muscle relaxation. Now, as I told you, because of the chemical stimulation, the blood, it gushes into these arteries of the penis, and this penis, if you see, they are filled with these spaces. These are hollow spaces, just like a sponge, and these spaces get filled with blood. So these spaces expand, and these veins which are there between the tunica albuginea, that is the surface of the penis, and this sponge, they get compressed. So there is decreased outflow of blood, increased inflow of blood, that causes a full erection. Now, as I told you, this erection can be genital stimulated, that is, it can be reflexogenic, it can be centrally stimulated, that is, it can be psychogenic, or it can be nocturnal or central originated. So, reflexogenic erections, they are induced by stimulation of the genital areas. So these are preserved in spinal cord lesions. They are short in duration and they are poorly controlled. The psychogenic erections, they result from memory, fantasy, auditory, or visual stimuli. They are more complex. While as the nocturnal erections, they occur spontaneously without stimulation or during sleep. Most of them occur during REM sleep. So these are the three types of erections. Now, a normal penile erection, as I told you, it requires a normal neural transmission of pro-erectile impulses, intact arterial blood supply, and functional erectile tissue in the corpus cavernosum. So anything that impairs these three processes will have an impact on the erectile function. Plus, it relies on a combination of psychological, hormonal, neurological, and vascular factors. So as a result, the erectile dysfunction can result if there is any disturbances in all these factors. So it is divided into psychogenic and organic causes. So erectile dysfunction, it is not only a single cause, it is always multifactorial. So depending on cause, we divide the erectile dysfunction into organic and psychogenic. Organic is further divided whether it's arterial. In arterial also we have whether it's arteriogenic, cavernosal, or mixed. Then we have got hormonal causes, neurological causes, endocrine causes, and anatomic causes. So these are various types of erectile dysfunction. So if you see the causes, it can be psychogenic. It can be because of performance anxiety, relationship problems, psychological stress, depression. This is because of loss of libido, over inhibition, and impaired release of nitric oxide. It can be neurogenic because of strokes, Alzheimer's, spinal cord injury, any radical pelvic surgery, diabetic neuropathy, or any pelvic nerve injury. These cause a failure to transmit the nerve impulse or interrupted neural transmission. It can be hormonal, which can be because of hypogonadism or hyperprolactinemia, which can cause loss of libido and inadequate release of nitric oxide. It can be drug induced, which can be because of antihypertensive drugs, antidepressant drugs, anti-androgen drugs, alcohol, cigarette smoking. This can cause central suppression, decreased libido, alcoholic neuropathy, and vascular insufficiency. Or it can be because of vasculogenic, because of atherosclerosis, hypertension, diabetes, trauma, Peyronie's disease, which can cause inadequate arterial flow or impaired veno-occlusion. Or ultimately, it can be because of systematic disease and aging, like old age, diabetes, chronic renal failure, coronary artery disease, which is multifactorial, resulting in neural and vascular dysfunction. So, what is psychogenic erectile dysfunction? So, the International Society of Impotence Research has defined psychogenic erectile dysfunction as the persistent inability to achieve or maintain erection, which is sufficient for satisfactory sexual performance, owing to predominantly or exclusively psychological or interpersonal factors. Now, which are the factors which can lead to psychological depression, psychological erectile dysfunction? So, performance anxiety. Performance anxiety is that if the person is not successful in the first sexual intercourse, this same anxiety can be carried at the subclinical or the subclinical level in the next performance, leading to erectile dysfunction in the next intercourse. There can be conflicts among the partners. There can be problems at work, at home, in the environment, which can affect the sexual intercourse. There can be emotional problems. There can be stress. There can be low self-esteem. There can be depression. There can be sexual inhibition, some cultural taboos or religious taboos. There can be difference in the sexual preferences or misperceptions of sexual identity. There can be fear of sexually transmitted infections or in pregnancy. There can be neurosis or psychosis. There can be sexual misbeliefs from poor sexual education. And it can be result of other sexual disorders like premature ejaculation, late ejaculation, or inhibited desire. So these are the various factors which can lead to psychological erectile dysfunction. There are some ruinous lifestyles which can cause erectile dysfunction. So many lifestyle factors that have been associated with erectile dysfunction, which have been proved in cross-sectional and longitudinal studies. So obesity and sedentary lifestyle, it is a clear-cut risk factor for erectile dysfunction. Smoking and alcohol consumption have been implicated in some studies. Increased level of sedentary behavior, it is strongly linked to erectile dysfunction occurrence in the aging men. Intervening on cardiovascular and lifestyle factors, they have got broader benefits beyond restoration of the erectile function. Pelvic surgery like radical prostatectomy can damage the neural transmission, lead to erectile dysfunction. Any surgery or any trauma can cause erection problems. Any spinal lesion like spinal cord injury can cause erectile dysfunction. Men with complete lower cord lesions, in that only 25% of them achieve erections. There can be impaired ejaculation and orgasm. Medical conditions like which affect the vascular and the neurological supply to the penis include multiple sclerosis, Alzheimer's disease, diabetes, hypertension, cardiovascular disease, and stroke. There are some drugs which can cause erection problems, but many of them, those three diseases, they are associated with erectile dysfunction, like antihypertensive drugs, antidepressant drugs. Then some recreational drugs that can also cause, or illicit drug use that can also cause erectile dysfunction. So this is a list of drugs. We have cardiovascular drugs, psychotropic drugs, recreational drugs like alcohol, marijuana, amphetamines, cocaine. Then we have got endocrine drugs like anti-estrogens, anti-androgens. Then we have got other drugs like cimetidine, ranitidine. Now in this, if you see the thiazide diuretics, which are commonly used among the hypertensives, why they cause erectile dysfunction is that spironolactone blocks the testicular testosterone synthesis and competitively binds to androgen receptors. Then if you see the alcohol, there is a development of peripheral autonomic neuropathy and behavioral changes. Then cimetidine, just like ranitidine, it decreases the libido and causes impotence through increased serum prolactin and blocking of the androgen receptors. So these are the drugs which cause erectile dysfunction. So illicit drug use like cocaine and amphetamine, as I've told. So erectile dysfunction has been reported in 36%, 39% reported decrease in the sexual desire, and 50% reported increase in the ejaculation latency. Also, it is commonly used with the use of heroin, amphetamine, and MDMA, that is ecstasy. Hypertension and erectile dysfunction are closely related. So 30% of patients of hypertension, they complain of erectile dysfunction. Endothelial dysfunction is a common cause of both hypertension and erectile dysfunction. And erectile dysfunction may be an early sign of hypertension. So high blood pressure can also cause erectile dysfunction, and antihypertensive treatment can also cause erectile dysfunction. In men with diabetes, almost 20 to 85% they suffer from erectile dysfunction. So there has been a study, famous study called Massachusetts Male Aging Study. In that they found 3 times the erectile dysfunction problem was 3 times more in diabetic as compared to the non-diabetic. Also, erectile dysfunction occurs earlier in the diabetic as compared to the with the duration of the diabetes and if the diabetes is inadequately controlled. That is with the raised HbA1c and the raised blood glucose. So diabetics should always be advised to discuss their condition with their physician. Men with depression, they are twice likely to develop moderate to severe erectile dysfunction as compared to the normal people. So men with depression, they are always advised to discuss their condition with their physician. Men with prostate problems also suffer from erection problems. So in patients underdiagnosed who have not been diagnosed with erectile dysfunction, there is a 14% of incidence of erectile dysfunction after transurethral resection of prostate surgery. There is a 44 to 75% of incidence of erectile dysfunction after radical prostatectomy. And there is a 75% incidence of erectile dysfunction in radiation therapy for localized prostate cancer. So men with prostate problem, they are advised to discuss their condition with their physician. Now, there is a new concept called ED equal to ED. So endothelial dysfunction in erectile dysfunction. Now, there are various factors like diabetes, hypertension, dyslipidemia, smoking. These all cause oxidative stress. Oxidative stress causes endothelial cell injury. Endothelial cell injury causes vasoconstriction, atherosclerosis, thrombosis, and erectile dysfunction. So erectile dysfunction causes nitric oxide deficiency in the vessel wall. So nitric oxide is very important, as I showed you in the earlier figure, because it initiates the cellular cascade of events. So nitric oxide deficiency in the vessel wall causes inflammation, lipid peroxidation, then smooth muscle proliferation, accumulation of lipid-rich material, and platelet activation and thrombus formation, finally resulting in atherosclerosis. So atherosclerosis means blockage of the arteries. So here we have compared the various size of the arteries. So a femoral artery is 6 to 8 millimeter in diameter. Carotid artery is this artery which supplies to the brain is 5 to 7 millimeter in diameter. Main heart artery is 3 to 4 millimeter in diameter. Penile artery is 1 to 2 millimeter diameter. So if 50% of the arteries are blocked, so if you apply 50% of the arteries are blocked, the penile artery symptoms, they are blocked 50%, they may cause erectile dysfunction. Similarly, if the heart artery is blocked, that can cause heart attack or anginal pain. If the carotid artery is 50% blocked, that can cause stroke. And if the femoral artery, that is the artery supplying the leg, is blocked, that can cause pain or claudication during walking. So you can see that the penile artery is half the size of the heart artery. So you can get an erectile dysfunction many years before you get a heart attack. So erectile dysfunction usually comes 3 years before you get a heart attack, making it the most common symptom in sign that the patient might have an underlying heart disease. So erectile dysfunction is an early sign of heart disease. Men with erectile dysfunction, they are at increased risk of heart attack. Men with erectile dysfunction twice likely to suffer from adverse cardiac events, and men who reported erectile dysfunction over the age of 40 should be thoroughly evaluated for an underlying cardiac condition. So how we diagnose erectile dysfunction? So basic workup includes a proper history taking, which includes medical history, psychological history, sexual history, physical examination, laboratory test, and medical and psychological history should be taken for both the partners. So in history, we take whether the patient is married or unmarried, whether he is divorced, what is the reason for the divorce. Like many times it can be because of sexual problem or infertility. Any children were there from the previous marriage, whether they are they have been referred by gynecologists for fertility treatment. So whether the present complaints are erectile dysfunction, premature ejaculation, unconsummated marriage, or sexual anxiety or sexual ignorance, or ejaculation problem like delayed ejaculation, premature ejaculation, absent ejaculation, or whether it is about the penile size, anxiety, or the penile curvature or penile pain. So these are various complaints where the patient can come to you with sexual issues. Since when the couple is, or the patient is facing this problem, when was the sexual function that time, when did the problem start, and what is the subsequent course of the problem. So what does he attribute the problem to? You should discover the underlying myths and conceptions. What is the current sexual status? In libido, you assess what is the sex drive. Do you feel the desire for sex? Do you feel like having sex, but you can't do because you don't get an erection, or you don't feel like having sex at all? So there is a difference between this. And also ask whether about the masturbation, because if the patient is getting erection during masturbation, that indicates that his pathways and the neural and vascular network is everything is normal, and even the desire is also normal. So arousal, you assesses the sexual orientation and the sexual preferences. So you should ask about what kind of sexual fantasy arouses you the most. When you masturbate, do you have fantasy about men or women? Do you had any sexual interactions with men? So that is to rule out gay sex. So in the erections, you ask about morning erections, erection during sex, erection during masturbation. So rigidity as judged by the patient subjectively and as compared with the erection in the clinic. Duration of erection, is it with ejaculation or not? So sometimes the patient can have an erection and then the patient says that he loses the erection fast. So you should ask him whether he loses the erection and then he ejaculates, or does he ejaculate and then loses the erection? Because if the patient ejaculates and then loses the erection, that means he is suffering from premature ejaculation. So erectile dysfunction is not the patient problem in this patient. So also ask about penetration, whether the penetration is partial or full, and whether it's painful for either of the partner. In orgasm, do you reach an orgasm? Do you feel satisfied at the end of the intercourse? In ejaculation, you ask like, do you ejaculate earlier than you want to? And are you satisfied with the duration of the intercourse? Is your wife satisfied? Or does she want you to continue for longer? And has your wife complained about the duration of intercourse? Now, sometimes what happens is that if the wife is not satisfied and she wants the patient to continue longer, that means, and the patient ejaculates earlier, that means the patient is suffering from premature ejaculation. Sometimes what happens is that patient ejaculates, or sometimes the patient wants to continue for long, and the wife has never complained about the duration of intercourse. In fact, the wife, many a time the wife says that it is painful for her, that is, she wants the patient to stop. So but still the patient wants to continue, and in this case the patient thinks that he is suffering from premature ejaculation rather than the wife. So in this, the wife's satisfaction is the most important. Sexual history, history of foreplay, history of manual stimulation to the orgasm. Then in treatment history, history of diabetes, hypertension, ischemic heart disease, psychiatric illness, hyperlipidemia. Any history of past surgery like pelvic surgery, prostate surgery, spine surgery. Marital relationship, what is the partner's interest in sex, whether there have been fights, stress, privacy issues. Impact of sexual problem on the relationship. Now, treatment goals. Is fertility the main concern, or treatment of erectile dysfunction the main concern? So is the patient really interested in therapy, or whether he has come here due to the pressure by the family or by the partner? Also interview the female partner. So many a time the female partner may not be available for the interview, but you have to call her separately and you have to interview her, because she may add some more details to the patient's statement, which might or may not contradict the patient's statement. She may have her own fears, doubts, or problems. There might be active participation from her, or it might be passive participation. She might be either cooperative, she might be accusative, she might be supportive, she might be angry, she might be threatening divorce, or she might be hostile. Also ask about female orgasms and satisfaction. So there have been certain tools which have been validated to assess the erection in the clinic. So the most commonly used tool is the IIEF score, also called the Internal Index of Erectile Function score. So second is the Erectile Hardness score. Third is the Quality of Erection questionnaire. And fifth is the SEER score, or the Self-Esteem and Relationship questionnaire score. Now I'll show you the International Index of Erectile Function score. Now, International Index of Erectile Function score, it contains 15 questions which cover over 5 domains of the sexual function. That is the erectile function, intercourse satisfaction, orgasmic satisfaction, and sexual desire, and oral satisfaction. So it has the gold standard measurement of erectile function, but it has been only used in the clinical trials. Second is the erectile hardness scale. So in this, either we use this ready-made block which has been provided, available in the market and provided by companies. In this, there are 4 rods of varying thickness and varying rigidity. So grade 1, grade 2, grade 3, grade 4. So you ask the male and the female partner to touch them, bend them, and see, compare it with the penis during the erection. Or if this is not available, you can use this regularly available. Like you can use a soft block of sponge as grade 1. Then you can use a peeled banana. Second is the banana with the skin. And third is a cucumber. So that is grade 4. So what are these grades? So grade 1 is that penis is large, but it is not hard. So that is grade 1. Grade 2 is penis is hard, but not hard enough for penetration. Grade 3 is penis is hard enough for penetration, but not that hard. And grade 4 is penis is completely hard and fully rigid. So if it is a grade 3, 80% can have successful intercourse. If it is grade 4, 94% can have successful intercourse. So there is a practical way to differentiate between organic from the psychogenic dysfunction. So organic dysfunction, erectile dysfunction, there is a gradual deterioration. There is reduction in the morning erections and the night nocturnal erections. There is no erection with masturbation. It is not partner specific. It is global, and there is presence of comorbidities like diabetes, hypertension, hyperlipidemia, dyslipidemia. Psychogenic erectile dysfunction, it affects the younger patients less than age of 30. There is preservation of nocturnal and morning erections, and they achieve erection with masturbation. It might be partner specific, and it is sudden onset, and there are comorbidities present. So on physical examination, we see the waist to hip ratio and also the waist circumference, that is to define obesity. We see for the presence of gynecomastia, which can show hormonal problems. We see measure the blood pressure, the peripheral pulses, focus neurological examination. Then we examine the penis to see for any present of plaques like Peyronie's disease. We determine the size of the testis and consistency of testis to rule out hypogonadism. And also we do a digital rectal examination or per rectal examination to see for prostatitis. Now in lab tests, we do the regular lab tests like HbA1c, that is the 3-month sugar control. Then we do the lipid profile, thyroid profile. Then we do tests to evaluate the hypothalamo-pituitary axis like the testosterone, free testosterone, sex hormone binding globulin, then prolactin, FSH, LH, and PSA above the age of 40, especially for candidates who are for testosterone replacement therapy. Then we do what is called as the office sildenafil test. Now this office sildenafil test is a dynamic therapy guided approach. So this is indicated in patients who come with unconsummated marriage, if there is a single unmarried male without any partner, if there is a young male with psychogenic impotency, and also to see for penile curvature. So in this, what we do is that we give a 100 milligram sildenafil tablet to the person, and we provide them pornographic pictures and auditory stimuli, and we ask them to stimulate the penis. If in half an hour, if he gets an erection, so that is a positive test. So mostly it is psychological. If the test is negative or poor response, then we go with the office intracavernosal injection test. In this, we use various agents like Bimex, Trimex, or papaverine with fluoropromazine. So 1.1 to 0.3 ml of Bimex is injected into the corpus cavernosa on either side. If there is good erections, it is psychogenic or neurogenic. If there are poor erections, we still repeat 0.3 ml. If still poor erection, we repeat 0.5 ml at the same site. If it is no erection, then that is arterial cause. Then additional tests are penile duplex ultrasound, that is to rule out arterial insufficiency, in suspected venous leakage, to rule out Peyronie's disease, and in case of traumatic penile injury. So this is a duplex penile ultrasound. So normally the peak systolic velocity is more than 30 centimeters per second. End diastolic velocity is less than 5 centimeters per second. And the resistance index is more than 0.9. In arterial insufficiency, the peak systolic velocity is less than 30 centimeters per second, and end diastolic velocity is less than 5 centimeters per second. In veno-occlusive disease, the peak systolic velocity is more than 30 centimeters per second, end diastolic velocity is more than 5 centimeters per second, and resistance index is less than 0.75. So these are the differences where you can differentiate between whether it is arterial or veno-occlusive cause. There are some additional tests for erectile dysfunction like arteriography. In this, we evaluate the anatomy, then the function. Then it is used after traumatic arterial disruption, after perennial compression injury, and also to plan for surgical reconstruction. Additional tests for erectile dysfunction includes dynamic infusion cavernosometry, which is not used nowadays. And second is cavernosography, where a dye is with the pressure inside the cavernosum is measured. And cavernosography is we inject dye into the cavernosal arteries, and we see for any blockages, and also to assess for venous leak. So we also have Regiscan, basically that is to differentiate psychogenic from the organic erectile dysfunction, and also to evaluate for nocturnal penile tumesis, that is the NPT. And it determines the number, the duration, and the rigidity of the tumescent episodes during the sleep. So this is the machine called Regiscan. It's quite an expensive machine, costs about 4 to 5 lakhs, and it is mostly used in the psychologist clinic. And this is the battery operated device. What we do is that these two rings are there. One is attached just 2 centimeters from the below the corona sulcus, and one is attached at the base of the penis. And then these recordings are measured in that during the sleep period, and this is connected to the thigh of the patient. Now, normal NPT is that 4 to 5 erectile episodes with a mean duration of 30 minutes or longer. An increase in penile circumference 3 cm at the base and more than 2 cm at tip. Then maximum rigidity of more than 70% at both the penile base and the tip. So how can I fix the erectile dysfunction trouble? Now, erectile dysfunction, olden days, lots of mini gimmick advertisements, like this was the advertisement in the previous papers during the 1900s. This was also like a pelvic belt. So this is like a vacuum massager. These were the olden days before the advent of the Viagra, before the invention of the Viagra. So invention of Viagra has changed everything. So main thing in the management of erectile dysfunction is that you identify and treat the curable causes of erectile dysfunction, lifestyle modification, risk factor modification, education of the patient and the partner, and counseling. So there are 3 therapy stages. In the first line of treatment, phosphodiesterase type 5 inhibitors with vacuum erection devices. Second line of treatment, intracavernosal and intraurethral injections, topical cream application, and low intensity extracorporeal shock wave therapy. Third line is the penile prosthesis. Now, how we clinically approach to the treatment of erectile dysfunction? We facilitate the patient and the partner's understanding of the condition. We make them understand the results of the diagnostic assessment, and we assess the patient and the partner's needs, their expectations, their priorities, and the preferences. We identify and recognize the associated medical and the psychological factors. The selection of the therapy is strongly influenced by the personal, cultural, ethical, religious, and economic factors. The presentation and stratification of therapy may therefore vary from individual to individual, culture to culture, religious persuasion, and from one economic tier to another. And prior to direct intervention, good medical practice recognizes the value of altering the modifiable risk factors. So if it is a psychogenic erectile dysfunction, psychotherapy or in combination with another therapeutic approach can treat psychogenic erectile dysfunction. If it's a post-traumatic arteriogenic erectile dysfunction, surgical penile revascularization can help. If it's a hormonal cause, testosterone replacement therapy is effective, but only after other endocrine causes have been excluded. So there are some lifestyle changes that may help with erectile dysfunction. So exercise is the most important. Weight reduction, limit of alcohol, stop smoking, a healthy sleep of 6 to 8 hours, control your blood pressure and the sugars. Now we come to the medications for erectile dysfunction. Now PDE5 inhibitors, these are the first line treatment. Now as I told you, the PDE5 inhibitor, they inhibit the PD at the level of this PDE5 enzyme, which convert this cyclic GMP to 5-GMP, prevent the degradation of cyclic GMP, which acts on protein kinase G, which convert the protein to protein P and causing lowering of the intracellular calcium, which causes relaxation of smooth muscle, vascular smooth muscle, causing the influx of blood into the corpus cavernosa. It is mainly indicated in psychogenic erectile dysfunction, mildly vasculogenic erectile dysfunction, and neurogenic erectile dysfunction. So these are various PDE5 inhibitors which have been invented: SILDENAFIL, Tadalafil, Vardenafil, Sildenafil, Mirodenafil, Evenafil. Sildenafil was the first which was invented in 1999, and after that came Tadalafil and Vardenafil, and latest is Evenafil. Now, if you see, the effect of Tadalafil is the longest, 38 hours it remains in the bloodstream, and Tadalafil is the one which takes more time to act. So it takes about 17, the half-life is about 17 hours, while in case of Sildenafil, the half-life is 4 hours. So time of use for everyone is almost 30 minutes to 4 hours before the intercourse. Only Sildenafil, it is 15 minutes to 30 minutes before the intercourse. Now, if you consider the side effects, headache, flushing of the face, dyspepsia, rhinitis is there. Back pain is more in Tadalafil, visual disturbance and more in Sildenafil. Now, in the visual disturbance, one should remember this important, that is non-arteriotic ischemic optical neuropathy. It is because of sudden blockage of blood flow to the optic artery. The risk factors are hypertension, diabetes, and hyperlipidemia. Contraindications to the use of PDE5 inhibitors are absolute contraindications are nitrate drugs, hypersensitivity, phenylketonuria like vardenafil. Then relative risk factors are history of myocardial infarction, stroke, or life-threatening arrhythmia in the past 6 months. Resting hypotension or resting hypertension, history of heart failure or unstable angina, and concomitant administration of alpha blockers. So why do patients continue PDE5 inhibitors? Because of unrealistic patient expectations about the drug, lack of patient education, patient resistance because of safety concerns and negative attitude, because of loss of desire for sex, because of prolonged sexual inactivity, and ED, which is unresponsive to medical therapy. So what to do if the PDE5 inhibitors fail? 20% don't respond to any PDE5 inhibitors. We can change to any other class of PDE5 inhibitors. We exclude the fake or the cheap versions of the drug. They should try at least 4 times or at least 2 drugs with maximum dosage before considering a failure. Re-educate about the dosing, about the timing, about adequate sexual arousal and interaction with fatty foods and alcohol. Check the testosterone levels for hypogonadism. You add a testosterone either in gel form or oral form or injection form. If the hypogonadism there, that is the testosterone less than 300, it increases the responsiveness to PDE5 inhibitors, improves the overall sexual function, and improves the erection. Now, low-dose therapy has been found to be very useful. It is safe and efficacious because of the prolonged half-life of Tadalafil, almost 17.5 hours. Because of lack of spontaneity with on-demand dosing, it creates a natural sexual experience for the patients without relying on on-demand dosing. It is mostly used in diabetes, post-prostatectomy, and post-radiotherapy patients. It is alternative for patients who have not responded to PDE5 inhibitors or to traditional on-demand dosing. The next in line is the vacuum therapy or the vacuum erection devices. So this is a vacuum erection devices. So the vacuum devices, they are to be slipped on to the penis and there is a rubber ring. So this can be either manually operated or can be battery operated, just a touch of button. And with the suction, the air is sucked, and with that the blood is sucked into the corpus cavernosa, and this rubber ring is slipped onto the base of the penis, and which has to be released within 30 minutes. So there is very low acceptance of vacuum erection devices, high discontinuation rates because of unnatural feeling of the erection, and also requires a mechanical procedure to produce the erection. Takes on an average 4 attempts to use the pump to become proficient. Takes 2 minutes to obtain the functional erection and need to place the concentration raise as close as to the base of the penis. The erection is limited only to 30 minutes and results are found in 80 to 90%. Good results if you combine the vacuum devices with the PDE5 inhibitors. Contraindications are like bleeding disorders, sickle cell disease, anticoagulation. Complications are like bluish discoloration of the penis, petechiae, numbness, pain after ejaculation, failure of ejaculation, high dropout rates. Second line therapy is intracavernosal injection. This is for patients who don't respond to oral drugs. This involves injection of agents that relax the smooth muscle into the corpus cavernosa. The penile erection will occur whether or not sexual stimulation is present after 5 to 15 minutes. So these are the various injections. Bimix, which is combination of papaverine and phentolamine. Trimix is combination of papaverine, phentolamine, and prostaglandin E1. And alprostadil, that is a prostaglandin E1 injection. So this, using a tuberculin or an insulin syringe, is injected into the corpus cavernosa. Here the patient is given a training how to inject, self-inject between 1 to 3 o'clock position at 90 degrees, with using the sterile aseptic precautions. So side effects are, there can be priapism, there can be hematoma formation, infection, bruising, pain at the site of the injection. Now, Muse is intraurethral suppository. These are practically not available in India at the present. You can order it online from Amazon. So this is the medical urethral system for erection. The short form is Muse. Product name is alprostadil. It is available 250 or 500 microgram. This is for patients who are not responding to oral pills or afraid of the injections. So here we have got a dropper which injects the pellet inside the penis, and it spreads through the urethra, acting on the cavernosal smooth muscles. Third line treatment, that is the final treatment, is penile implants. This is for patients with erectile dysfunction who fail to respond to oral medication, penile injections, vacuum devices, or any other modality, or where the conservative therapy is contraindicated, like PDE5 inhibitors when the patient is taking nitrate drugs, penile injections as in patients with warfarin or history of priapism, vacuum devices in patients with anticoagulants, or the patient's choice after trying other treatments. If patient is not satisfied in the other treatment, he can opt for the penile implant. Patients having advanced Peyronie's disease, patients with penile trauma, pelvic trauma, patients having priapism, or fat patients having a buried penis. Also, it can be used with penile reconstruction. So there are two types of implants. One is called malleable implant or the non-inflatable implant. So this is a simple, like a silicone implant, which can be bent to any proportion. So this implant is placed in either of the corpus cavernosa using under a surgical procedure. And whenever the patient wants, he can just bend it here, keep it inside the pants. Whenever he wants, he can make it straight. Second is the inflatable 3-piece penile implant. So as you can see, these are the hollow silicone penile implant. These are connected by these tubes into a pump, which is connected to a reservoir filled with water. Now, these penile implants are placed into the corpus cavernosa. The pump is placed inside the penis, and the reservoir is placed below the umbilicus, below the bladder. Now, whenever the pump is pressed by suction, the water from this cylinder rushes into the pump and into these tubes into the hollow cylinder. As a result, the penis becomes straight. When the performance is done, again you press the pump and this water returns back from the pump into the cylinder. So this is about the penile implants. Now the newest therapy is low intensity shockwave therapy, where low intensity shock waves are given to the penis. Their mechanism is they cause neoangiogenesis, that is, they cause formation of newer blood vessels because of these low intensity shocks. So there have been many papers where low intensity shock wave therapy have been used for erectile dysfunction. The latest, again, new addition is this P shot or the M shot. So this P shot or M shot is basically non-surgical treatment option for erectile dysfunction, where platelet-rich plasma is injected into the corpus cavernosa. Now, how is platelet-rich plasma prepared? Blood is collected, platelets are separated, and the middle part is the platelet-rich plasma, which contains a mixture of platelets and plasma. This is collected into a syringe, and this is injected into the penis. So this platelet-rich plasma has some vascular endothelial factors which help in new angiogenesis, that is the formation of new blood vessels. So Elon Musk and Bill Gates should ideally team up to invent a cure for erectile dysfunction, and it will be called as elongates. Just joking. So thank you everybody. So we should not aim for a bent Eiffel Tower, but we should always keep it straight. So thank you, everybody. Thanks for attending the session. And if you have any questions, you can mail it to me or you can see me personally. Thank you.
We have few questions which I have posted in the So thank you so much, sir. On the behalf of the organizer, I would like to thank you for your insightful and educated talk. Sir, with this, I'm ending the session now. Thank you.